Right, welcome back. We're still having a discussion on utilizing the opportunities brought about by COVID-19 in ensuring that we strengthen our health systems, and we have guests from AMREF Health Africa, Dr. Patrick Kagurusi. We have Mr. Dennis Chivira, the Executive Director of HEPS Uganda, and just next to me is Gabula Paul, the Program Manager at ACHEST, and we have Dr. Orek Isaac, who is online. He's a Senior Medical Officer in Lira District. We are also going to be joined by Mr. Tabu Fred, the Country Consultant for Results for Development, and he has also done some work under the Ministry of Health. We had also invited Dr. Richard Mugahi from the Ministry of Health. Unfortunately, he was unable to make it, but we do hope that the ministry is picking some notes from the discussion here. And if you have just joined, you didn't miss quite a lot, because we still have some time with you, about an hour and some few minutes ahead. And at this point, I will let in Mr. Tabu. And Tabu, I want you to explain to us what the impact is if we cannot manage to strengthen our health systems generally on the population and development of the country.
Oh, yes, thank you so much, Walter, and all the panelists present today. I think the most critical barrier to okay, maybe I'll bring it in the sense that we still see a lot of mortality in the children, the maternal, but also in the newborn. And health commodities are really pivotal if we are to look at reducing those indexes. Therefore, I really think the most critical barrier, or the most important aspect that we need to improve, is basically improving the availability of these commodities we use in the prevention, but also in the treatment of these conditions, the maternal, newborn, and child health illnesses. So in my own opinion, we have to explore opportunities on how to increase access to these key health commodities if we are to reduce on these indexes in these mortality indicators in the country.
And of course, government works hand in hand with CBOs, or non-government organizations, and community-based organizations, and this work feeds into the community systems. But with all the organizations in the country, the non-government and the community-based, that have been providing a service, and I'm very sure that when you leave Kampala, the city, most of the work, especially regarding health, is done in partnership with NGOs upcountry. But what do we need to improve for service delivery within the existing systems that we have created? And this, of course, will cut into sustainability of the commodities that we are talking about here, and services to do with sexual reproductive health. I'll start with you, Chivira.
What do we need to improve service delivery? I think it's all these things we have been talking about. Certainly, the health system, they are building blocks, and the World Health Organization provides 6 building blocks. Governance is the overarching building block. Yeah. And I think many times we will fail because of that governance. So what we really need to do, most times health has been treated as, just going to a health center. And that's where most of the funding has been put. I think the government has now taken on a multi-sectoral approach, which means all sectors should contribute, because ideally all sectors matter to health, whether it is finance or education, whether it is water and environment. All these build up to health, and we should see it that way. And so the governance component is really important. How do you coordinate this multi-sectoral dispensation? But also financing. We've talked a lot, and we've talked a lot about financing here. In order for service delivery to happen, there must be facilitation for that to happen. We've talked about some districts that do not have field positions, even for district health officers. That's funding. We've talked about not having even a person to work on medicines at a district. That's money. And so financing is really important. There are other building blocks, information. I'm losing the others now, but it's all that has to happen in order for you to be able to deliver. But although we many times underestimate the issue of money, and sometimes we say, okay, how are we using the little we have? I think even this little we have is not enough. And it's dependent on people coming from outside. It's dependent on people paying and having to sell property as and when they need care. How do we mobilize so that we can have sufficient funding to be able to enable the delivery?
Okay.
Can I add something?
All right. You can chip in.
Yeah. Thank you so much, Dennis. I would want to add something small. Of course, we have the building blocks.
Yeah.
And since time immemorial, we are talking about these building blocks. I remember when I was growing up as a young boy, my father was a local chief, and he made sure that every week he would go around the villages to see that Walter has a latrine, to see that Walter has a katandal, to see that Walter has a charge in Lusoga, where I come from, a granary where you keep your food. But this has died. We have structures that are non-functional. I think the most important thing that while we have all these building blocks, we need a mindset change. We need a mindset change to ensure that if the LC1 chairperson has been appointed as LC1 chairperson, everybody must believe in him. Everybody must run around this person to ensure that each village is becoming a model village. But we have leaders who are, I think, because of money, they have become money-minded, and things have become non-functional. So I think the whole thing is not about the building blocks, not about money, it's not about health workers. Yes, health workers and money, but we need a mindset change. We have money which is being misused all the time. We have health workers who are now selling in Owino market. We have nurses selling in Owino market. We have nurses who are in Nakawa market. Why don't we mobilize resources and bring these health workers to go and deliver the services we want? So I think it's a mindset change. The issue of leadership and the governance is very important. We need very strong leaders. We need capable leaders. We need skilled leaders, and we need leaders who have the will to deliver Uganda out of the mess we are in now.
Okay, I wanted us to hear from Dr. Orek. From your experience working in Lira, what is the delivery system like, especially for commodities to do with sexual reproductive health services? We know of instances where, people want condoms and IUDs are delivered. I have covered stories, some time back where IUDs were delivered, and this particular community preferred to have condoms, and they never used the IUDs until they were expired and they were left for waste. So Dr. Orek, what is it like in Lira, and of course picturing in the COVID-19 situation?
in Lira, we actually receive supplies from national medical stores like any other part of the country. And that, of course, that also depends on our orders when we put our order in time and according to the quantification that is needed to supply the catchment area or the catchment population facility. And that has always been done by our staff when it is guided by the office of the DHO, by the assistant inventory manager of the district. But in most cases also, we don't receive every commodity that is ordered. I think because of sometimes the stock out at the national medical stores or any other thing like that, because when you order, just as you're saying, when you order and then sometimes you receive less, or you receive even the things that you've not ordered more than the quantity you need. I mean, you've ordered, but then you receive more than the quantity you need. And also sometimes you don't receive what you've ordered. And so that discrepancy or such gaps in supply has always made, of course, service delivery difficult, because when we put our order, as I said, we make quantification according to the catchment population. And by the planning, it is expected that people in the catchment population should be able to access service by some percent, like if the women in reproductive health age, they should be able to access the services, all the almost 11 components of the sexual reproductive health. So when the commodities are lacking or they are not supplied in full, then before the quarter ends, the health workers now will be running facilities sometimes without the necessary commodities. But by and large, I want to say that I would think that government have tried, because right now we have the opportunity as the health facilities down here, that we have the RBF, the results-based financing funds that come to facilities through the Ministry of Health. And the RBF funds come by what each facility is able to pull down to them. Because as the name suggests, or as the name says, it is actually results-based. You're given money according to what you've done. And so when your data is speaking a lot that you've done, and then it is verified by the district team, then you pull more money. And the more money you pull means the more improvement on your budgeting. And when your budgeting is improved, that means you can pull more resources from the medical stores, which can be, because we are allowed to procure commodities and drugs and other supplies from joint medical stores. For example, even this, just last week, we put in our order to joint medical stores, except that certain commodities were also still lacking, even medical equipment. We had a budget from that total money which was given to us. We wanted to make an order of close to 10 million, but then we were not able to put an order of 10 million because other commodities were lacking at joint medical stores. So we had to reduce our budget or our request to joint medical stores. So the most important thing is that at the lower health facilities here, government has put in an opportunity of RBF funds. And now it depends on leadership, just as Fred was talking about. It depends on leadership. If the leadership is working with the team down here well, and then their work speaks out well, and then they're able to pull down more resources, that is able to supplement the mainstream government supply of financing system. So that is the situation. And when I would say that we have run that for now more than one financial year. And I think a lot of learning and experience have now occurred among the health workers, among the in charge of health facilities, And that means in the next year coming, we should be able to do much even better. And so with the advocacy, which is running on, I want to believe that the health team should be able to perform at a better level. The only problem that probably will stand, Walter, is that the planning at the main level has not changed, yet the population dynamics, population growth have occurred, and it goes on every other year. So there is also a planning bit, because these RBF funds cannot supplement enough, but it is doing a great job. But then the mainstream planning by government and by the Ministry of Health and other development partners have got to follow, or have got to match with the population dynamics. Because if we don't do that, then we are not going to meet the targets, and that is not going to translate into the expected service delivery capacity. And then at the end of it all, there will be a gap, and that's what leads to mortality. That's what leads to disease outbreak. That's what leads to many other problems coming up from the community or society. So in a nutshell, what I am saying is that planning should move together with population change. Two, the managers of the health systems at different levels have got an opportunity to now work much even better with the Ministry of Health opening a window for RBF, and of course the PHC funds, and then of course other development partners. And that probably would be able to make the health system much better driven than before.
Okay, Doctor, I also know that there is a question of choice. I visited a couple in Kabale some days back, and this lady was using an implant, but she felt it wasn't going to do the work, and she also decided to take pills at the same time. It was quite a weird story, but it was a disconnect to do with choice and having the right information. How do you relate with the community there in terms of providing information and the right choices? Dr. Rek, this is to you. If you had the question, how do you relate with the community in terms of helping them make the right choices as regards the sexual reproductive health services?
Walter, with that, we have all what is called integrated community outreach activities. And that has been our key driver to reach out to the communities. And whenever we move out with a larger team to implement integrated outreach activities, we do a lot of health education, and that with continuous activities has caused behavior change among the population, the women seeking for family planning, women coming for antenatal care, then men being involved in the reproductive health care programming of the women. And we've also had a community dialogue. Just as we're speaking now, today we've been reviewing malaria program in our sub-county here, working with the district team, with the malaria control program system. So whatever, the community dialogue, the integrated outreach activities, and then of course the program that is here at the facility, which is at the static center here, where we do health education, we do health promotion, and then working with our public health staff. We have the health inspectors, the health assistants, and then we move out and we do all this together. It has caused a behavior change among the communities that has increased the demand for the health services. And that has also a lot impacted on our health indicators. And so that working at the lower health facilities, I think the better way to relate with the community is to engage them, working through the VHTs, working through the community linkage facilitators, working through the young people and adolescent support groups called the YAPs. All these auxiliary staff brought on board has brought a better communication between the health workforce and then the community. Of course, we have the Health Unit Management Committee. These are very, very important linkage between the health workforce and then the community, because they advocate that community should come to access services, and then also they advocate that the health workers have got to be on duty, arrive on time, and do their work right. And this has made our work easy and has made the linkage between the health facility and the community very good. And so I do think that working with all the stakeholders, as I said, the Health Unit Management Committee, working with the community setup, the community leaders, and then the VHTs and the linkage facilitators do improve a lot on the relationship between the health workers and then the community. And I think that should be built up much better so that we can keep building capacity every other time, and then services will be much improved.
Thank you very much, Dr. Reg. We will definitely come back to you shortly, but I want to quickly go to Dr. Kagurusi, and he brings in another aspect of results-based financing. Now, I managed to visit Namisindwa district when it was granted a district status. They had a health center 3 at the time. I'm not sure if it was upgraded now to a 4. And, you know, there was an extremely poor road network. We spent about a day to get to Namisindwa. So if you talk about results-based financing, and you have a scenario of health workers working in Namisindwa district at the time, where these services or, you know, deliveries will take that while to be delivered. Probably the person who wanted them today, you know, leaves and they stay within more than 30 kilometers of the health facility and they can't return tomorrow. If you choose to use this kind of excuse me, strategy, how then do you equate it to other facilities that, you know, have a very good road network? You know, does that mean that they're underperforming? What do you think about that strategy?
Thank you, Walter. But I want you to allow me some 2 minutes to first add on to the discussion that we've been having. I think it is really clear that all the investment that has happened onto the health system that we have is not going to yield results because the burden is unsurmountable. So while we are concentrating on the supply side of things, leadership, financing, service delivery, health workforce, we need to look on the events in the communities, because that's where the burden is coming from. Yeah. Every time we try to pour in money, try to provide services, the problem keeps growing. And so we must see how to address the problem. And the sexual reproductive health burden that we have stems from gender inequalities that we are seeing in our society. You carried the story on COVID about a lady who had a young girl and was trading or giving the young girl to men in order to get some money. The girl is abused. The girl is going to be pregnant, even yesterday there was a story about pregnancy. We are seeing many teenage pregnancies. But the decision made by an individual in a community to sell, if for lack of a better word, the daughter to get a teenage pregnancy, most likely contract HIV, to be defiled, is where we need to tackle. So that the society gets transformed, like he said, to a time where a woman who would have done that, or a man who would have abused a young girl, turns into a protector of that girl. Then you will not have the many teenage pregnancies, you will not have the many new HIV cases, you will not have the insurmountable demand caused by sexual reproductive health burdens onto the health system. The other thing is, again, the gender transformation is related to, okay, who has the power to decide? Who has the power to decide on resources? When the leader is thinking about the need to make the road to the health facility, are they looking at even the user? Are they thinking about the woman who needs to come to the health facility and come back again, and whether this woman even has the resources to do so, whether the transport is available? Are they having the resources to do that? So I think there needs to be a whole transformation of society. Professor Omaswa, who should have been here, has a very famous quote: health is made at home and only repaired in the health facility. If we can deal with curtailing the demand and the burden that comes as a result of these inequalities, pressures, and abuses that happen in the community, we'll maybe reach an equilibrium faster, which is the question you were asking my friend Gabula here. We reach the equilibrium faster, where the resources invested can meet the little demand that will be there if the society is transformed. Now, going to the question of results-based financing, it's a very interesting and a very good strategy, because it buys results rather than investing in the input. So the people who are providing the services are challenged but also motivated to deliver onto the results. And that results-based financing also causes a transformation of the health system, because now people start thinking, okay, if I'm supposed to get funded, what results must I produce? They even become more accountable. And I think the system improves in so doing. So results-based financing is good, but like you pointed out, even if you have results-based financing, but the road to the facility is not there, or is so bad, then the health facility, like the doctor was talking about, will not produce the results it should have, because the people will not be turning up anyway.
I'll let Gabula chip in before we can link to Tabu.
Thank you so much. Yes, like Dr. Kaguru says, the issue of the strategy of result-based financing is good, but of course it also has its own challenges. With all due respect to our health workers who are providing a service to this country, amidst all challenges, you find some of the figures are inflated, because if they inflate the figures, then they can, get more money out of the results they are buying. But again, the other issue is we are failing to look at a pregnant woman as a whole. We are looking at a pregnant woman in terms of bits and pieces, in terms of projects, in terms of an immunization project, in terms of NC project, in terms of preeclampsia, in terms of all these sorts of things. So if we looked at a pregnant woman, if we looked at an adolescent, if we looked at Walter Mwisdi as a whole, it will be very easy to offer services. The reason why we are having and continually having these challenges is because we are looking at, for example, you are saying Namisindwa is not accessible. We are also looking at Uganda in bits and pieces. If we looked at Uganda as a whole country and we planned for the whole country and say every district must, every health facility, wherever you are going, there must be a tarmac road, we wouldn't be having all these challenges you are pointing out. So I think the issue of mindset I talked about needs to also come in, and we look at a human being as a whole from a human rights perspective, than just looking at a woman because she's pregnant, then an NGO, a certain ministry looks at this woman as a project. We therefore need to look at this woman in terms of her gender, issues that Dr. Agus is talking about in terms of education, in terms of nutrition, in terms of livelihoods, in terms of transport, in terms of how she's being managed, in terms of leadership and governance.
Leadership and governance. Part of the strategies that were achieved during this project, which is concluding, is the ability to leave, you know, a mark on ground. The organizations that you worked with, the youth that you worked with, these are people who are now going to remain and advocate for, you know, these services even when the project has gone. And I want Tabu to, you know, tell us how then do we utilize the opportunities within COVID-19 to strengthen the health system.
Thank you so much, Walter. I really think there's really a lot we have learned from this COVID in terms of utilization of services at the service delivery points. In terms of dispatchment of resources, because as one of the presenters said that there were some allocations at some point of funds meant for some program towards COVID. So yeah, in that perspective, I really think this should be a learning kind of experience to advocate, especially for financing for these programs. Like, for example, RMNCH or MNCH as a program, we know very well that it is suffering funding gaps. It still has funding gaps. If you look at 2016 to current, you'll see that the financing for we have been having funding gaps for RMNCH commodities. So what I think as a lesson we can learn is we need to advocate for more funding, such that when some of these scenarios come, we are not so much affected. Like, for example, right now, it's very, very difficult to say that you want money towards maybe a particular program. Most of the money now is going towards COVID. So I think, in my own way, I think that we need to learn from COVID, and then we explore our efforts. We explore our efforts to increase the funding, especially for RMNCH, because we have seen that due to uncertainties, there may be challenges. And then one other thing before I forget is we are looking at some of these successful programs like HIV and malaria. For them, they have managed to reduce the funding gap to almost zero. Actually, if you look at financial year 2019-2020 and onwards, you see that for them, the funding gap is like zero. There have been a lot of advocacy, both from government of Uganda in terms of commitment, but also from the donors. So I still think that this could be also part of the lessons we should learn. What have they done better that we can still copy and apply to the area of RMNCH.
Okay, thank you very much,
to
Tabu. The question of sustainability is what I want us to shift to, and of course, utilizing the opportunities by COVID-19. And I know all of you here have, you know, particular fields that you follow. For example, Dennis, you are looking majorly at commodities and availability. How do we sustain what we have developed so far in the last 5 years?
How do we sustain what we've done the last 5 years? You see, for our country, if we are to do anything, and anything good and lasting, we must be able to capture that young person. 50% of our population are below the age of 15. If you also look at what research has shown us, is that a rural girl will have on average, will have a first sexual encounter at the age of 16, will get married at the age of 18, and by the age of 21, yes, 24, they will already have over 3 children. No, at 21 they will have already 3 children, but they will get their first contraceptive use when they are 24. So we are reaching them when it's too late. So how can we, in order to sustain what we have done, how can we engage and how can we reach this young person? How can we reach them with information so that they can make informed choices? How can we reach them with the services that they need? And therefore, the Ministry of Health program to try and create safe spaces for these young people, as and where they are, I think that's really crucial. It needs to be emphasized. I think the policy framework is also really important, because without, we've been struggling with sexuality education framework for schools for years. And so there is no guidance. We do not have a sexual reproductive health policy for the country. That's a problem. So it creates a vacuum in terms of how we operate. But if we are to be able to sustain anything we have done, and to be able to see an incremental improvement, we need to be able to capture this young person. The SDG targets for maternal mortality to reduce it to by 2/3, global mortality by 2/3 to 70 deaths per 100,000 live births. At the moment we are at 336, which is, so we still have a long way to go. But we shall not be able to make any movements when a rural girl is having sex at 16, getting married at 18, and by 24 is when we are reaching her with the contraceptives. How do we reduce this unmet need for contraception? How do we ensure that we have services that could be accessible for the young person? So for me, in a nutshell, to answer you, how do we sustain the gains we have made? We have to ensure that we are reaching that young person.
The target is the young person. Dr. Kagurusi, I want you to give us your view of what the opportunities from COVID-19 are, you know, because I think it is important to even first of all establish what these opportunities are. Have we learned anything from COVID-19? It's not over yet. We still have probably a long way, no shape yet, but 6 months down the road, what do we see?
Okay, thank you very much. I can't speak for everybody on what they've learned. But I think regarding sexual reproductive health and rights, COVID-19 has taught us, one, that if another pandemic, assuming this one ends, comes up and is similar, we now know what's going to happen, because the infrastructure of finding out about the pandemic and its science is already there and has been built. But we are going to also learn that women who are going into labor will die. So we need to prepare early, because even in Kampala here, you had the cases. A woman, because of a lockdown, can't move to a clinic and I think we should learn that even in these circumstances, like you started, life still goes on, and therefore the maternal mortality will have to be a focus. And we have to do more than we are doing now to prevent such a mortality from happening from causes that can easily be prevented. So that's going to be one. Two, we have learned that sexual and gender-based violations are going to increase in such a pandemic, and therefore must be ready. So when we start talking about a pandemic like this one, we should also start campaigning against a rise of sexual and gender-based violence, because this will happen in a similar pandemic. Three, I think we've learned that integration of interventions is the key, because in our programming, for example, had we not integrated the COVID intervention within the normal work that we are doing, I think we would have missed the opportunity to even get both interventions concurrent. The other thing that we have learned from COVID is that it will definitely disrupt every system, and therefore the system must be galvanized to ward off the threat of such a pandemic. Healthcare workers should receive protective equipment. The leadership should be able to look in a forecast manner to know that if health workers are not protected, then they will not be there to serve the people who need services. There should be a leadership that is able to predict that unless decisions are made to invest together in COVID and the normal services, then we will not be having the right leadership. To speak a little bit to what Dennis Chivya said, such a pandemic will disrupt systems, logistics and supply systems, and there will be shortages of medicines. So if a pandemic again happens like this, then you must quickly move to make sure that the supply chain is not affected, because if it is affected, then you have shortages of supplies. But also my real point that I like what he was alluding to the young girl. I think we should focus and know who is now in a pandemic like this one. Somebody will carry the burden of sexual and reproductive health violation, and that will be a young girl and a woman of reproductive age. And therefore, this person must be protected. The relations around the father or the uncle who is abusing this girl, we should be able to predict and say, this is the message you are going to target to these people. The immediate relations should protect the young girl. Institutions like churches, traditional institutions, should also prepare themselves, or even right now start campaigning against violations against these young girls and women. Then the policy framework, the leadership, the structural interventions should make sure that this particular young girl, adolescent, is protected. And use the social influence as the media. You should make sure that, again, these young girls are protected, and beyond telling us that the event has actually happened, and the campaign should go to prevention and protecting these young girls.
Okay. I see you have been noting down some points you probably want to share with us.
I think, just to add on to what my colleagues have said, I think we need to take advantage of the current structures we have. We already have structures in place. We need to take advantage of these structures, make them more functional. We're talking about money, we need to fund them. We're talking about skilling them, we give them skills and guidance and supervision to ensure that they deliver on their mandates. For example, I'll share one small story. Recently, through the HSAP project, we did a pilot in Ingora district in eastern Uganda. And within a period of 6 months, because of good leadership, because of supervision, because of commitment, we've seen results. We've seen numbers increasing in terms of deliveries. We've seen VHTs reaching out of the homes. And surprisingly, this project has been picked on by government, and we've developed a national strategy on community engagement for COVID. And it was launched recently, and I think the media, you know this very well, maybe you were there. It was launched by the office of the Prime Minister of Uganda. So we need to take advantage of the structures that are delivering. There are so many good-willed people who can deliver in this country. Yeah.
Okay, so Dr. Orek, if you're still with us, I want to hear from you about sustainability. What have you picked from COVID-19, even when we are still, going through the period? But what do you have so far that will ensure sustainability of, all the advocacy work these people and, their teams have been trying to implement down at the level of, say, your health facility there?
Thank you very much, Walter. What I have learned, or we've learned now from the pandemic, is that epidemics or pandemics may still come up, and everyone has to be prepared, because when we talk at the community level, but also we need to address health at the household level. And then, so I think one of the things that have to be done is that people have to be helped to fight poverty, because one of the biggest problems that has punctured the system is the capacity to what do I call it, to what I think what the World Bank calls it, the purchasing power parity. People have got low purchasing power when it comes to healthcare, because healthcare left only to government has a big challenge in sustaining it. Just as one of the colleagues said, referred to Professor Maswa, who said health is made at home. Indeed, we should empower people to make health at home, to do everything possible to improve their nutrition, to improve on their household settlement, and then to improve on their economy, working through agriculture. That probably will help communities to be empowered to stand out in good and bad times. And also, we should be able to empower the health workforce by making sure that we have, first of all, enough of them on the ground, and then we provide what is necessary for their work, so that when we expect them to produce or to produce results on every indicator, then they should be having all that is necessary, if not all, at least some good percent of what is necessary for them to produce the expected indicators, results on indicators. So I think for me, my biggest problem is that people should fight poverty. Once poverty is fought, and then we also deal with ignorance, then we can be sure that community will always take information and work together. You can imagine that COVID-19 has come with a lot of force and has forced people to wash hands. And from my own experience is that washing hands alone with water and soap has changed the behavior, has changed the disease trend, much as we still have a lot to face in the health care problem. So I think with that, people should adopt to new life. People should not go back in terms of public health measures to protect their own health care, and then to protect the young ones. And then I think we should stress that young girls all should go to school, because the more they stay out of school, the more vulnerable they become. So education system have to be strengthened. If the UPE now that has been moved to USC, if we can have even higher level of education, have people pay less, that would be much better for people, for girls to be at school, because dealing with teenage pregnancy is more difficult than having somebody who is mature enough and going into now for reproductive lifestyle. So we need to look at those areas, and that probably is going to change the trend of life. So Walter, I think from my side here, my biggest enemy, or the biggest enemy, is poverty. Once we fight poverty, we can be able to face many other forces like facing the giant, and we shall win it as a country.
All right, Doctor, I'll also ask you to give your parting shot at this moment, and we will thank you for joining us from the start of the show until now. Thank you.
I beg your pardon?
I'll ask you to give your parting shot, then we will let you go and, continue serving your community.
Okay. Thank you very much, Walter, and the whole team from AMREF Health Africa, and then, of course, HEPS Uganda, then, of course, the ACHEST, that you've had a time to work with us. I think we shall remember HEPS Uganda a lot, because when we hosted the pre-eclampsia symposium here in Amach for the whole of Lira district, where the celebration was here, we were able to now hold firm onto factors that were necessary to be put in place, making sure that our BP machines were working, and making sure that we had drugs in place, like magnesium sulfate and calcium gluconate. So I want to thank the whole team of HEPS Uganda and AMREF Health Africa and other development partners, and of course the government of Uganda. We are able to work, and I want to say that we're going to try as much as possible to work with the team to sustain the gains we have had, and so that the community can benefit. I want to wish you all the best, and the whole country. Enjoy yourselves.
Thank you very much, Dr. Isaac Orek. He's a senior medical officer in Lira district, and of course he has given us part of his time and shared what is actually on ground. But we have been alluding to one major point. Let's target where the problem is. But do the people actually know what they are going through? Does the population actually know that we are the source of the problem? I think that is one thing that I need to understand, and I want to hear from you, Dennis. You've been doing, several studies as HEPS. Do you find the community, one that understands where they lie?
More and more in this country, we find that the community harmony, I don't know, the issues of leadership actually that Paul spoke about. I think more and more we see a community which is almost, I would use a word maybe in disarray. Education, I think, needs to, we need to do more in terms of education. And that it will go a long way in terms of building leadership, the leadership system within the community, to be able to empower. NGOs have done something, but it's little disseminated projects here and there in terms of empowering communities. But also there hasn't been a good framework in which to do that. But again, a lot lies within the leadership in at the local community level. You see, basic things in the community, bulungi bwansi, where people used to clean. You go into a community, people are dumping rubbish everywhere, just in front of their houses. And so basic hygiene matters. So I think in terms of how this can be improved, we need to do a lot more in terms of empowering leadership at the lowest levels, but also going back to the primary healthcare system that we had, because we have lost that, and a lot has gone wrong with that.
Okay, Tabo Fred is still online with us, and I will ask him to also give us his parting shot and what he thinks that we can improve together for a lasting health system going forward in the future.
Thank you so much, Walter, moderator. For me, I have basically 2 points that I think will be so critical. My side is commodity availability, the country, at the service delivery points. One, government of Uganda should come up and increase commitments towards the financing of sexual and reproductive health commodities. We have seen that we have been having donors or development partners partnering with government in this space, like AMCHIP, like UNICEF, like UNFPA, but we have seen some of them winding up, like UNICEF, for example. They have been financing the community's intervention, that is the ICCM, where they have been covering basically pneumonia, diarrhea, but also malaria, one of the 3 leading cause of mortality in the under 5 especially. So I really think that if government should come up and take the biggest proportion, the biggest commitment, because these partners are so unreliable now. 2, we need to look at the e-services. We need to look at the electronic logistic management information systems. We have seen successful programs like HIV, malaria, and so on, TB. They have high visibility. They have visibility from the central level, the district level, but also at the service delivery points, meaning that planning and the quality of data for planning is very easy, it's quality, and it's very easy to plan because you have visibility at all levels. So I really think that it is also something that has been lagging for RMNCH. We need to invest more in the electronic logistic management information system to increase visibility from the central level to the service delivery points. Yes, so those are the 2 main interventions or investments that I see that government of Uganda can explore to increase especially access to these key commodities that are used in the prevention, but also treatment of these MNCH conditions.
Thank you very much, Tabu, and of course, thank you also for sparing time to give your thoughts to this discussion here. And I'll go straight to Dr. Patrick. We have one thing called commitment, which is very key. I know for sure that there is money that was appropriated in the Ministry of Health to handle the issues of sexual reproductive health, but then a huge chunk of it was then diverted to buy mama kits. Whereas mama kits are important, if you divert from your commitment to support sexual reproductive health services for mama kit, then one may want to wonder where our opportunity cost lies. What do you think about the level of commitment from our government? And of course, its impact.
Walter, you're putting me in a very difficult position. But let it suffice to say that I think we can do better. We can invest more into healthcare and our health system, and we have the opportunity of options, especially the health insurance scheme. If government can really demonstrate commitment by letting out the health insurance scheme, it will help pool funds to invest into the health system, and how I wish it would target providing services on sexual reproductive health, and that means really incentivizing the whole system. That's where I'll leave that. But also, I think besides working to strengthening the health system, For me, I think we should have a total transformation of the community to really address these gender inequalities that eventually manifest as maternal mortality, as teenage pregnancy, as malnutrition in children, name it, because the power to decide to allocate resources and make people benefit from them is leaning somewhere and not to the most affected people. So I think we need a whole societal transformation to address this sexual reproductive health burden. Those would be my really 2 points. Strengthen the system by even alternative financing, because you can look at how much money, for example, people have in circles. They've accumulated a lot of money. Why couldn't they do it for their health? Yeah. And then to answer your question earlier where you asked, do the people know what their problem is? Everybody, if one of us grows up with an ambition, a girl wants to be a doctor, but the life is that ambition is cut short because there was a teenage pregnancy somewhere. Then they can't continue. So they know, you see, they know, but we are not giving it enough attention. So strengthen the health system to respond to the burden of sexual reproductive health, but also transform the society to make sure that it can deal with these problems before they become burdens.
Okay, I know the after effects then realized later on in the future, where you have, dropouts, you have all these figures flashing in our faces in terms of number of deaths at both ends. Yeah. But there's always been one question: what is the role of men? And I want to start with Gabula here.
You're also putting me in an awkward situation. I think as men, one of the most important things is to be role models, especially to our young people. If we are role models, there are so many people we quote in this country and beyond, whom we quote every day. I don't want to overemphasize, for example, my executive director, Professor Francis Omaswa. Everybody quotes him. Why? He's a role model. Everybody looks at him to become somebody that just mentioning your name, somebody will, I know him, he's this, he's this. I think as men, we need to become role models to our young girls, to our young boys, and show them the values, the core values of growing up in an organized society. But like then said, our society is in disarray. There is no role model you can see around to look up to. I think that is also an issue we need to think about. And of course, to promote the issue of gender equality, issues of gender balance, those are things that really have gone disarray and they need to be tackled. Who is tackling them? Like I said, we need a mindset change. We need our leaders to come out strongly and defend the rights of the undefendable, those who are not able to defend themselves.
There are issues of the budget. Would you, want to add a comment, especially, commitment to financing for health?
Yeah, of course, at Archest we've been talking, of course, in the past there was this issue of the Abuja Declaration, 15%, and then later it has become a stale story. It's no longer a catchy story anywhere. We are advocating for capital expenditure. Like, let the government spend, like Dennis and Dr. Kagurustu were talking, the population has grown, but we are spending less than the population should be able to consume. So I think let's go by per capita expenditure, and I think that will make a big difference. Otherwise, just to say we are allocating a 2 billion to the health sector, what's your basis to allocate that kind of money? Is it somebody just sits in a room and says 2 billion for this, 2 billion for this? I think let's use statistics, let's use research, and let's use the available information we have. We have a lot of planning institutions in this country, but with due respect, I think we are not using them enough to plan for this country.
Okay. Yeah. Dennis, I'll take your parting shot.
Well, my parting shot, and I'll say, I'll not use the word government, I'll say the state, because health is the obligation of the state. Yeah. The state needs to reclaim ownership of the health sector from donors, from well-wishers. And that's one. And it will do that by improving. The investment needs to be seen. The investment needs to be seen. And that's in terms of money, in terms of stewardship. We cannot leave our health system to a foreigner. You cannot leave your home to be managed or financed by another man. So government needs to take responsibility. Two, as others have said, community education and empowerment. We need this young person that we've been talking about to come up as someone that can make informed decision on their lives. Once we are able to achieve that, I think we shall go a long way.
Okay. All right. Dr. Patrick, do you want to wrap it up in about a minute?
Yeah. First of all, thank you to my colleagues, distinguished panelists. Thank you to you, Walter, for bringing us here to discuss this very important subject. For me, it's really to voice the commitment of organizations like AMREF, and I'm sure our colleagues, to continue the cause of uplifting communities from the challenges that they're having. And we commit to really invest and into community transformation, especially because that's where the burden is. Then we shall meet the systems improvements halfway, and we hope we shall be able to achieve that in our lifetime. How I wish it would happen when we are able to see it. But we are committed to working towards that, but really causing a lasting health change in the communities in Uganda and in Africa as a whole.
Okay. All right. Gabula, you want to chip in very quickly?
Yeah, very quickly. I think it will be unfortunate if we don't say thank you so much, Minister of Foreign Affairs, that has been behind
Netherlands
this, the Netherlands Ministry of Foreign Affairs that have been behind the funding for this project. Thank you so much, the Dutch people, for being with us all the time. You've done a lot of investments in this country and in Africa. We thank you so much. In Africa, they say when you lose somebody and you are mourning and somebody comes to mourn for you, mourn more. I think we need to mourn more and advocate for better health services to ensure that this country is a better country. We also want to thank the Dutch Embassy in Uganda. They have been very friendly to us. All the time we've been meeting them and providing us technical support on the things we need to focus on. And then my last message to the viewers, I think let us allow our structures in this country to function. If we don't let our structures in this country to function, we will not move a mile. Thank you so much.
Okay. Thank you very much, my studio guests, and of course those that we had online. If you have been watching the discussion here, of course you now clearly know that your health begins with you and it begins at home. It is your responsibility to ensure that Uganda will not suffer the burden of, having to deal with treating and preventing and dealing with the after effects of disease. These can be prevented and controlled. But also, like it has been clearly said here, we need to see a time when we are thanking our own government for meeting the commitments they have actually set, the targets they have set. For example, financing the health budget, locally 15%. That should not even be a story that we need to talk about again. We need to be thanking the government for doing this, not thanking the sponsors or the donors or, like they said, another man trying to finance your own budget. But that said, we do thank you for your audience. My name is Walter Mwesije, and Maureen Nambalira has been on sign language, and the team behind the cameras. We do thank you for being a great audience. Have a very good evening. The Beat is coming up.